Good afternoon. For some reason, I often am the speaker after lunch, so we'll try to make it as entertaining as possible, but I will not be offended if you doze off. After the peach cobbler, sometimes it's really hard to resist a few snoozes. And I will try not to be distracted. I am a preacher's child, and I'm a church musician, so when I saw the Hammond organ, I was like, woohoo, maybe I should not lecture and we should have a concert instead, but we'll try to go ahead and talk about maternal mortality. Today, I really want to talk to you about disparities in maternal mortality. Our disparities in maternal mortality are really a world health crisis and should be a source of national shame. And so as we go through this lecture, what I'm hoping for us to think about is how we, as providers of women's health care, can help change the course and the dialogue around maternal mortality. Okay, so I have no disclosures, and of course, these are just our objectives. We're going to talk about complications, disparities, and then in the end, I want us to talk about how to implement a management plan. If I can get okay, I'm going the wrong way. There you go, I got it. All right. So it is no secret that maternal deaths are on the rise. If you look here, this is the United States in black, and this is the developed regions of the world. Developed regions of the world have had a decrease in maternal mortality somewhere around 40 to 50%. Unfortunately, the United States has had an increase in maternal mortality of 136%. Now, why are our maternal deaths on the rise while other developed countries' maternal deaths decreasing? If you look, again, this is the United States, 26.4 out of every 100,000 births, compared to the UK, which is second to us at 9.2, and then continuing down to our neighboring Canada, 7.3, and then Finland, of course, being the lowest at 3.8. Now, what are the causes of maternal mortality in the United States? Cardiovascular disease. Cardiovascular disease is the leading cause of death in women regardless of age, and is the leading cause of death in women who are pregnant. Now, you say, well, Dr. Graves, what about hypertension? Well, that's part of cardiovascular disease. But if you look here, cardiovascular disease, 15.2%. Other medical complications, non-cardiovascular, 14.7. But what I want you to do is I want you to put this 15.2%, which is cardiovascular disorders, along with this 10.3, again, which is cardiomyopathy, along with this 7.4, which is hypertensive complications of pregnancy. So you have to say that cardiovascular disease is the leading cause of death in pregnant women. Okay, I'm trying to get my thing to move, sorry. Now, here we go. So, more importantly, this is from the Centers for Disease Control in 2011 per 100,000 births. If you look at our maternal mortality by race, women who are African American or Black, 42.8 per 100,000 births, other races 17.3. If you really think about it, and especially for women over the age of 40 who happen to be African American, your chance of dying in childbirth is the same as if you lived in Ghana, which is a third world country. How can we, as the country of plenty, think that that's absolutely okay? So, the good things is that in the United States that we've reduced maternal mortality since the 20th century. Does anybody know what the average age life expectancy for a woman was in the year 1900? And I use that because that's the year my grandmother was born. Huh? 47. Anybody else have anything? 52. Anybody else? 40. The average life expectancy was 40. And the reason is because women died in childbirth. So we have come a long way No one expects, I had this conversation with the Catholics when they were telling me about Pope John Paul II and the writings of, Pius, the First and Aquinas. I said, that's all fine and good, but that was the 15th century and people expected women to die. No one expects a woman to die in childbirth these days. So we have done a good job. Again, what I showed you, there are 29 countries with lower maternal mortality rates than the United States. We talked about the fact that African American women are 4 times more likely to die. If you happen to be Hispanic, Asian, or Pacific Islander, you're 60 to 70 times more likely to die than a non-Hispanic Caucasian woman. And recent studies have said that these deaths are preventable, up to 50%. So that means that we can do a better job. So in 2010, the Joint Commission kind of jumped onto this, and they wanted to start to address maternal morbidity. And so they looked at some things that they thought that we could do differently. 1, we don't control blood pressure very well. 2, we don't diagnose pulmonary edema in patients with preeclampsia. 3, after a patient goes to cesarean section, we don't look at vital signs. And because we don't pay attention to vital signs, people hemorrhage after cesarean section. Then Suzanne Baird and I did a study for her doctoral program looking at, can we predict whether or not we can manage these patients or recognize signs of compromise in the obstetrical patient? And the answer is yes. But our recognition of compromise is different from that of someone in the ICU. So we looked at things such as respiratory rate, less than 12, greater than 24. In the ICU, you have to have a respiratory rate of greater than 40 for them to be concerned. We looked at blood pressure sustained, systolic greater than 160, diastolic greater than 110, less than 90/60. Anybody know that if you go to the ED for hypertensive crisis, the blood pressure they're looking for is 180. And in some places, they're looking at 200. So it is no mistake that this is why we have issues with mortality and morbidity in pregnancy, because of the fact that our numbers and data are different. So when we're relying on our ED colleagues or our medicine colleagues or someone else to take care of these patients, they may miss signs that are very important to being able to diagnose the patients in trouble. The other thing is that often one of the things I think that we often miss is anybody ever have a gut instinct that your patient is not doing well? Or that the patient is agitated and anxious? One of the nurses came out just the other day and said, I can't believe this patient in room 2, she's being a diva. Well, she was a diva, all right. Right after that, she had an amniotic fluid embolus. And her anxiety and her need to have somebody come in the room and all these other things was a portraying of what she felt was about to happen, that sense of doom. So it's important for us to be able to recognize these things if we're going to make an impact in taking care of patients. Now, fast forward to 2018. So in 2010, a Joint Commission said, hey, we have a problem. But now it's become a big problem because who knows that we have a problem? The news media. And so this is a USA Today July 2018 headline. Hospitals know how to protect mothers, they just aren't doing it. I don't think that's the case. I think that we sometimes are just missing what we need to do. It is not that we just aren't doing the things that we need to do, but I'm going to talk a little bit about some of the things we can put in place to make it better. This is the Black maternal mortality crisis in the United States. This is out of the New York Times, why America's Black mothers and babies are in a life and death crisis. Now, one of the things I do want to point out is that I do not think that maternal mortality and infant mortality are separate. And one of the reasons that maternal mortality and infant mortality are separate, as much as we don't want to think of this way, is the baby is really an end organ. It is at the end of the placenta. And the placenta is a vascular compilation of vessels that reflects the vascular compilation of the mother. So if the mother's vascular compilation, we just talked about cardiovascular disease, if her vascular composition is failing, so will the placenta. And if the placenta fails, the baby will be in a failing environment. So we have got to start looking at things as one instead of trying to look at things as separate entities. So This is Black Mothers Keep Dying, Giving Birth. Sharon Irving's story explains why. I'm going to tell you the story of this mother. She was a PhD researcher. You know what she researched? Maternal mortality. She went to the emergency room 4 times. Each time she said she was short of breath. Each time they said they looked at her vital signs. Her blood pressure was only 160/80. Of course, what did I say the ED usually uses? 200. They gave her some 180 to 200. They gave her blood pressure medicines and sent her home. She came back again, and after the 4th time, she went home and she passed away. Now, this is someone who knew the system. This was someone who was a researcher. So think about all of our patients who don't know the system and how this can be an issue for them as well. Well, what is driving maternal mortality? Poor maternal health. Well, like I just said, when women come to us in poor health, then we have to spend time getting them into some semblance of good health before we can even talk about getting them to have a healthy baby. Healthcare systems and access to care. You know, I'm on the CDC committee for bias, and I had a patient not too long ago who was an immigrant from India, and she needs a lung transplant. And one of the things they said is, is she a, quote, good transplant candidate? And they didn't mean, is she a good transplant candidate physiology-wise? They meant, is she a good transplant candidate? Does she have the money to live as a transplant candidate? Bias. And this was at a very good academic institution. Social determinants of health, we're going to talk about social systems. And then, of course, unfortunately, women's health is often caught up in political agendas instead of good medical science. We're going to talk a little bit about maternal health. I weigh like this, don't you? Especially after I eat. It makes it much better. You'll never be overweight if you do it this way. So, one of the things that's driving our maternal mortality crisis is obesity. This is in 2016. I want you to look at our state. You know, we always like to be on the forefront of things. And so here we are. You know, thank God for Mississippi, Alabama, Arkansas. They can kind of gird us up a little bit. And the largest state in the United States is West Virginia with 35.5. Now, you think about that. That means that 35.5% of the population is overweight, which means 35.5% of the patients that we see in our office are going to be overweight, because our pregnant population is a reflection of the general population. Then let's look at age-adjusted obesity. If you look by race, again, you can see why this may be driving. This is the non-Hispanic white, non-Hispanic black, non-Hispanic Asian, and Hispanic. If you look, the total for non-Hispanic, for Hispanics and for non-Hispanic blacks is almost 50%. But if you take out women in the population for non-Hispanic black patients, almost 60%. That's 6 out of 10. For Hispanics, 1 out of 2. So this is where we are already when we come to take care of our patients. And so we have to think about, and this is to age 20 years and older, our population. So we're going to have to think about how we start on this end. So when the patient comes to see us on this end, we are already starting behind the 8 ball in caring for these patients. Well, why is that a problem? Because when you weigh over, moderate obesity is associated with the increased risk of hypertension, thromboembolism, labor induction, cesarean section, and wound infection. That's from 90 to 100 kilos. That's moderate obesity. But when you look at severe obesity, the risk of pregnancy-induced hypertension goes up to 3 times, thromboembolism 4 times, the need for cesarean section almost 3 times, wound infection 5 times, and then anesthetic complications. So if we're already starting here and we're already having issues with, and this is the patient population we're taking care of, we're already starting with a high-risk population regardless of the other comorbidities that come with that population. The next thing is the cesarean section trends in the United States. Cesarean section trends, does anybody remember when you used to push for vaginal birth after cesarean section? I think David probably remembers that. We were all on the committee. And then something happened. ACOG came out with all these rules. You got to be in the house. You have to be, everybody, anesthesia has to be available in 30 minutes. And guess what? We're like, oh, we're not doing that. That's too much trouble. I can schedule my C-section at 7:30. It takes me 30 minutes to do a repeat. If I have to do a bilateral sapropingectomy or tubal, that may be 5 more minutes. I can be in my office at 8 o'clock. And I don't have to worry about the patient rupturing her uterus. I don't have to worry about having any medical legal implications. And so therefore, as vaginal birth, that's the cesarean section, went down in 2005, total cesarean section rate went up. And primary cesarean section rate has gone up as well. Now, people say, well, that's because we're not doing a good job of monitoring labor. What did we just notice when we looked at patients who have a BMI who weigh more than 120 kilos? What goes up? Labor induction. And when you have to induce labor because you're post-dates, what goes up? Cesarean section rate. And then when you talk about obesity, you have to be, I'm going to speak as a real clinician, you have to think about it. Hey, my patient has and this is a true story, my patient had a BMI of 99. 99. Then I had to start thinking, can I stat section this patient? What's that answer? No. If I have to stat section her, can I put her to sleep? What's that answer? No. So what is the safest thing probably for this patient? A controlled C-section, right? Because if I get into trouble, I can't get out of it. My other question was, her legs were large. So if I get a laceration and I have to repair it, will I be able to visualize it? No. So when people say, well, that's because we're not doing labor well, it may be also because our patient population doesn't labor well or is not a candidate for labor anymore. And that's just something we have to have some real talk about. Again, this is body mass index as a measure of obesity. This is Gillespie in 2016. You can see here, again, this is normal weight versus African Americans, overweight. Now, the one thing I want you to be aware of is that body mass index is not always predictive of health complications. So for people who are African American, you can see overweight here, health complications. But when you get to the obese population, especially in our rural areas, it also affects our Caucasian patients as well. And they're more likely to have long-term health complications from being overweight. This, again, the mortality associated with cesarean section, postpartum death is 3 times, almost 4 times higher. And then, of course, as we talked about, thromboembolism, infection, and anesthesia. So let's look at something else. This is the cesarean section rate by region. Who has the highest cesarean section rate? We do. What was specific to us? What does this look like? It looks like the obesity map. So it is clear that obesity is having an issue, has a function on our mortality and morbidity rate, especially in the South. Well, let's talk about hemorrhage. The uterus puts out 600 cc's a minute. Anybody realize that? And guess what? You know, the cardiac surgeons think they're the bomb, right? But guess what? They get to put theirs on bypass. Our uterus does not go on bypass. It would be great when it starts to hemorrhage. We could say, ooh, let's get that cannula out right here. We can put this blood and circulate it back in. But it doesn't work that way. So in 8 to 10 minutes, our patients can be dead. And 8 to 10 minutes. And one of the problems is that injury to the birth canal and or any time the uterus fails to contract properly can lead to this issue. Since we have a rising issue with cesarean section, guess what else we have a rising issue with? The morbidly adherent placenta and placentation. How many have been involved in a placenta accreta or procreta in the last year? I remember when I was in residency, I remember the first one we ever saw. In our institution when I was at Vanderbilt, I remember she was a dentist's wife. No one knew that she had it. I remember that she passed away. But then we didn't see them very often. But sometimes we do one a week. Because as patients have more cesarean sections, the more likely we are to have a morbidly adherent placenta. And if they have had 3 previous cesarean sections, then you need to know that their risk of having a focal or accreta is somewhere around 50%, 44%. So you have to be suspicious and make sure you're delivering her in a place that has blood supply. So the causes of maternal deaths, of course, is inadequate resources of personnel, like a home delivery. Now I have to tell my patients, when Beyonce and Jay-Z deliver at home, that's not how you deliver at home. You know, Beyonce and Jay-Z probably had a whole hospital, had anesthesia, had an anesthesia machine. You have none of that. So we have to think about when these patients and try to make our hospitals more friendly so those patients who want to deliver at home will still deliver in a hospital setting with backup. Fail to prepare for obstetrical hemorrhage. We have a birthing center at our hospital. We have 2 rooms. They're away from everything. They have aromatherapy. They have a ladder. They have a ball. They have candles. They have everything you need. But guess what else the patient gets when she gets there? A help lock. Because when a patient begins to bleed, it's hard to get a help lock in. So she gets a help lock. Now, she may never need her help lock, but she gets a help lock. So those are some of the things like we need to think about. Delayed recognition of hemorrhage, delay in treatment of hemorrhage, and treatment failures. One of the things we know, when I was a resident, no one ever wanted to have checklists, no one wanted to have protocols because they didn't want us to learn cookbook medicine. But you need to cookbook your hemorrhage. So I'm going to ask you some questions. How many of you practice in a small hospital? Level 1. How many of you know how many units of blood you have in your blood bank? How many people know if you have a massive hemorrhage, how soon you need to call out for other blood? If your blood bank calls out. See, these are the things people need to know in order to make sure that the patient is delivering in the right place and making sure you do the right thing. I remember when I was at Vanderbilt, one of my residents said, oh, so-and-so did a hysterectomy. I said, yeah, she already knew she only had 8 units of blood and the hysterectomy was going to save her life. Yeah, it would be great to put in a Bakri, but you know, that is the Bakri and the balloons and all those other things, those are the luxury of places that have a lot of blood supply. When you only have 8 units of blood and you know you only have 8 units of blood and your patient is hemorrhaging, then you can be life-saving by doing what you need to do. So I pointed that out to the resident and they kind of looked at me and went, oh, well, that's a great thought. So you need to educate your staff about hemorrhage. You need to run protocols in your hospital. You need to have a hemorrhage cart. Who has a hemorrhage cart in their hospital with everything on it? Everybody needs to know where the hemorrhage cart is. You need to be prepared for hemorrhage. You need to run drills in your hospital. You need to be vigilant. Often what happens when patients bleed is I call it seep out. You know, they bleed a little bit. They have a little bit on the pad. We don't weigh it. We think it's okay. We come back 30 minutes later, they've seeped out again. They put it on the pad. We think it's okay. They come back 30 minutes later, they bleed out. We put it on the pad. And so you have to be vigilant. You need to be weighing or at least making sure you're recording your estimated blood loss. And everybody needs to be trained. And the training does not need to be just on labor and delivery. It needs to be on your postpartum floor. At Midtown, where I practice, the 3rd floor is our labor and delivery and our antepartum service. Our 7th floor, all 77 beds, are postpartum. Now, if you think about it, that's 4 floors up. And you know what the culture used to be? Is the postpartum floor just called for labor and delivery to come upstairs and treat their hemorrhage. But now we have a cart on the floor, and we actively train our postpartum nurses how to manage hemorrhage as well. This is a meta-analysis of hemorrhage outside the hospital. If you deliver at home, these are for low-risk patients. See, this is some of the data that our patients are using, so you can refute it. So I'm going to tell you what the problem in this study is. First, this study is done in Europe. Secondly, this study is done with trained midwives. So at home, they had 32.6 in the meta-analysis versus in the hospital 67, and they concluded that a planned hospital delivery was an increased risk for hemorrhage. Yeah, well, if you have a midwife at home and you have services, then that might be the case. And these were in low-risk patients only, which I'm not sure we have any of those readily available anymore. Again, this is about racial and ethnic disparities in care. Postpartum hemorrhage, again, the reference is non-Hispanic whites. You can see African-American patients, Hispanic patients are much more likely. The adjusted odds ratio here, this is unadjusted, this is the adjusted odds ratio. African-American patients are more likely to have obstetric hemorrhage and delays in and an adverse maternal outcome. Well, what about hypertension? So the prevalence in the United States is 7%. About 6% of women have pregnancy-related hypertension, and about 2% of patients have chronic hypertension, but there's significant racial and ethnic differences. Of course, you know there's new classifications for hypertension, and from ACOG, and that 130/80 is now considered hypertension, as we used to consider 140/90 hypertension. And this is reflected in the new ACOG technical bulletin, which was actually published at the end of the year in 2018. So hypertensive disorders have increased 25% since 1987, and it's a leading driver in maternal mortality and morbidity. And again, we talked about the racial disparities. So this is another test. How many of you have hypertensive protocols in your hospital? You know ACOG actually has a sample order sheet in their technical bulletin. For preeclampsia, you can pull it out. For acute hypertensive emergencies, every hospital should have a hypertensive protocol, and you should be able to respond to patients in the hour after they get there. Again, this is in New York. This is Tanaka et al., looking at hypertensive disorders in pregnancy, a 10-year longitudinal study. Again, African Americans were increased over Hispanics and other populations. Again, this is black mothers. If you look at disparities, obesity has increased 21%, hypertension has increased 22%, and diabetes has increased 28%. And during that time, maternal mortality has increased as well. Hypertensive rates are different in African Americans versus other populations, with African Americans being the highest, followed by Native Americans, non-Hispanic whites, then Hispanics, and then at the end, Chinese. This is a longitudinal study, 657 non-pregnant women. Hypertension was 6 times higher in non-Hispanic black women, but guess what? Black women were less likely to be diagnosed and less likely to receive treatment. What does that mean for you? That means that patient who This is between 24 and 32. What those are childbearing ages. That means that patient is going to show up in your office untreated. And so you're going to have to start with treatment before you can even talk about other issues. This is the treatment of severe hypertension. Again, this is the ACOG technical bulletin, and it was updated in 2018. This is how we treat hypertension. 160 or greater, 2 readings 15 minutes apart. 110 or greater, 2 readings of 15 minutes apart. These patients should be treated within an hour after they get to your institution. Prompt recognition and treatment will improve outcomes. Anybody ever seen anybody stroke? I have. She stroked in our level 2 hospital ED. She couldn't talk for 2 days. It's very important that we entreat these patients and not say things like, and one of the reasons that it drove me to get a protocol for our hospitals, I would hear things like, oh, well, she has chronic hypertension, so she can tolerate higher blood pressures. Anybody ever heard that? Okay. Now, does that make any sense? If you have chronic hypertension, what's been beating on your vessels? High blood pressure, right? So you might be even more likely to stroke, right? Or have you heard things like, well, we don't want to get her, we're going to give her magnesium and that'll bring her blood pressure down. Or let's just get her an epidural. None of those are treatments for hypertension. The treatment for hypertension are appropriate medications. You want to prevent end organ damage, you want to avoid a seizure, but you don't want to return their blood pressure to normal. Again, I show this because I told you this at the beginning. This is the definition of hypertension in other populations. I want you to see greater than 180/20. Treat if greater than 220/120. That's the American Heart Association. The other thing about hypertension is when you send patients home and they have preeclampsia, you need to give them appropriate discharge instructions. How many people are treating their patients outside the hospital with preeclampsia who are still antepartum? I still do occasionally. They need to have appropriate instructions to come back for new or worsening complaints. They need to be able to monitor their blood pressure at home. But more importantly, our maternal deaths don't occur in those patients. They occur after they deliver, because we don't give as good of a postpartum instructions as we should. How many people are seeing people come back 5 days after delivery with high blood pressure and pulmonary edema? I'm good. I thought it was a Nashville phenomenon. I'm glad it has spread throughout Tennessee. So it's important for us to give, this is where our patients are dying. These patients also are at risk for long-term hypertension, diabetes, and cardiovascular disease. Now, the newest cause for maternal death is opiate use. And as we have restricted our ability to get pain pills from providers, I've seen an increase in heroin. Now, Tennessee used to just give our pills away. You go to the doctor and get some. So we were the #1 prescribers in the whole United States. But as we've cut down on the ability for these patients to get them from a prescriber, they get them from off the street, and they are using heroin. In fact, I was very glad. Last Wednesday night, I stayed up for 4 hours and got home at 2 o'clock because I sat at a patient's bedside who had endocarditis, who was septic, who had actually has lesions on all 4 valves from shooting up heroin on the street. Now, she's still alive, thankfully, but these are this type of patient is going to, #1, need resources, and #2, if she is ever able to get clean, she will need 4 valves replaced from her endocarditis. Again, you can see Tennessee, while we cut down, we still are #1. But as we cut down, what we'll see what other states have seen is an increase in heroin on the street. And if you look at our data from the Tennessee Maternal Mortality Review Committee, Tennessee is one of the few states that doesn't have a disparity in maternal death. You know why? Because of opiate use. If you take out the opiate use, then our disparity is just like everybody else in the United States. African Americans are more likely to die. If you put in opiates, that disparity goes away. So opiates are clearly something that we're going to have to address as a cause of maternal mortality and other substances as we go forward. Now, there are some things we need to improve. One of the things that we need to remember is that most of these women are victims of childhood trauma. They did not choose to use opiates. And in fact, some of the stories they will tell you is that they will tell you things like, I was given pills before my uncle sexually abused me. That's how they got hooked on opiates. It's not the fact that they just decided, oh, I'm going to go get some opiates. And yes, some of them have dental appointments and things of that nature, but many of them are treating their mental illness. We have got to develop a better communication system, and we've got to develop better mental health systems if we're going to address this issue. And we've got to enhance families, patient and family engagement in order for us to be able to address this. Because this epidemic is what's going to, in our area of the country, is what's going to be driving our maternal mortality and morbidity as we move forward. Now, in 2012, the Society for Maternal Fetal Medicine decided we put the M back in MFM. I don't know how we took it out, but I guess we did. And so what we decided is that we were going to enhance training, improve medical care, equip providers with education, and then address gaps in research. So one of the things that we need to address are hospital systems. I love this, because see, in Nashville, we have all these hospitals right together. Level 4 maternity center, level 3 to 4 maternity center. This is Vanderbilt level 4 maternity center, Meharry level 3 maternity center. And guess what the distinction is? They're all within walking distance. So if we have all these hospitals within walking distance, why are our mothers still having significant morbidity and mortality? One of the things that we're going to talk about is care. Where your patient gets is seen may determine her outcome. When you look at disparities, one of the things that you see is that women of color and poor women tend to deliver in level 1 hospitals, whereas women who have resources tend to deliver in a more appropriate center for their medical complication. Okay, this side moves faster than the other side, sorry. Now, this is not about closing small rural hospitals, but making sure that patients get where they need to go, and we need to develop a culture of collaboration. So, one of the things I'm working on in Nashville, since cardiovascular disease is the leading cause of maternal mortality, and since at least 2 of the hospitals in Nashville classify themselves as cardiovascular centers, maybe 3, and at least one of those hospitals does more deliveries than in the state of Tennessee, shouldn't we all be able to work together to come up with protocols? Why is it that we're competing? You know, this hospital gets, we have tubs, so then they get tubs. Then they get cameras and we get cameras. But that's not what it should be about. We should be collaborating because no one is going to take care of all these women. And everybody needs to know something about how to care for these women. So we need to develop a culture of collaboration. And we also need to develop a culture in which we as providers are okay with sending our patient to where they may get a higher level or better level of care. And again, these are just the definitions. Birthing center, level 1 does uncomplicated pregnancies. Level 2 can take care of some appropriate high-risk conditions. Level 3, more complex conditions. And level 4 facilities have on-site conditions and hopefully some transplant services. Well, now we're going to talk about social determinants of health. One of the things we're going to have to look at is why our patients don't come see us. So remember that patient I told you I was taking care of? You know what she did for 2 days, she and her partner? He picked her up and she peed in a cup. Said, did you think about coming to the hospital? No. And part of that, I think, was because they thought they would be judged for what they had been doing. And part of that was because they didn't have the resources to get there. They had to wait on a ride. So we do need to look at this if we're going to make an impact on maternal mortality, lifestyle factors, and how we network together. In Nashville, when my patients are late, anybody ever make their residents ride the city bus? Okay, this is an exercise for you, Dr. Adair. Your residents need to ride the city bus. Then they can figure out why the patient's late. Because in Nashville, to go from the east side to downtown, you have to change buses downtown. And so if the downtown bus is late, then you're going to be late for your appointment on the west side. And so because of that, then we say, well, the patient's late for her appointment, we can't see her. Well, the problem is that there's a social, this is an issue. How they're able to get around affects how they have access to healthcare services. And then we look at bias in our systems. Implicit bias versus explicit bias. Well, you know, anybody who's been watching the news knows that there's a lot of explicit bias going on lately. Expressed directly, they may be aware of their bias and operates consciously, like I like whites more than Latinos. But then there's the implicit bias, expressed indirectly. People are unaware of their biases, operate subconsciously, like sitting further away from the Latino than the Caucasian or the white individual. Or I will tell you one of my personal biases, being lazy. So when the patient comes, I grew up, my parents were older. I grew up as parents of the Depression. I had a job since I was 14. So when my patient tells me, well, you know, I'm late for my appointment because I didn't get up on time, it makes my head spin. But I'm aware of that. And so, because in my mind, I'm thinking, boy, why are these people so lazy? But the truth of the matter is that she may not be lazy at all. She may have 4 children. She may be depressed. She may not have good social support. I don't know those things. But those things are often unspoken when we take care of patients. And in fact, the patient who threw an amniotic fluid embolism was African American, and that she was being a diva. And when I pointed out to them, hey, you know, that's because she was being, quote, demanding. And then you know what they said to me? Well, her nurse was African American. I said, yes, but we have the same biases. It's not about race as much as it is about who we are as a people, and we need to be okay with that. And say, hey, you know, this bothers me. Like I said, I know. You tell me then you get to the thing and you seem unhurried that you were late for your appointment. But I still need to see you because you have diabetes, hypertension, you have, and this is a true patient, you have hyperthyroidism and pulmonary hypertension, and you have nephropathy. You could die. And I need to see you and take care of you with your medical problems despite that and give you the attention that you deserve. This was from the SMFM report that we participated in. They believe, 84% believe that disparities, they strongly agreed that it affected how they practiced, but only 29% thought their biases affected how they cared for patients. So we as a medical community are going to have to look, if we're going to change how we think about these things, we're going to have to look at ourselves and make sure that our biases aren't affecting. And like I said, they're not always racial. Sometimes they're socioeconomic. Sometimes they have to do with same-sex couples. We have to be aware of how that may help keep us from taking the best care we can of patients. Again, this is explicit bias is what's spoken, and then implicit bias is what's underneath. So as I leave you, I'm going to talk a little bit about a call to action. Because if we don't, as medical health care providers, leave our walls, it says, I believe it says, you have a virus from your computer, it's gone straight to your brain, I hope you have a backup copy. If we don't leave our walls and our towers and really make a difference, this is why I fought so hard for maternal mortality in Tennessee, we're going to still be talking about this, I'm afraid, 5 years from now, because we've been talking about it now for about 10 years. So we have got to put our prejudices and preferences aside, and we have to advocate for these things. Preconception counseling. There should be no reason that patients come to us with hemoglobin A1Cs of 13 and 15. Anybody see those all the time? You know why? Because they haven't had care. Contraception. If your hemoglobin A1C is 13 to 15, should you really be having a baby? Breastfeeding. I am always amazed how we are so worried about breastfeeding, but it's okay for us to have people with their breasts hanging half out, not feeding it, doing anything with them. We have to think about that. Women's rights. Time off when you from pregnant. Time off. The ability to have families without a penalty. And in medicine, we have not done a good job about that. People take off. We don't always think about that as a life pause. We think of that as life ending. And then involving partners in the parenting process. And then we have to think of cultural issues. If your patient comes from a family that doesn't trust doctors, you have to gain their trust. Doesn't trust the healthcare system, you have to make sure they trust you. Try to engage them in their care. We have to start today with our insurance companies. I'm proud to say that I recently worked with United Healthcare on a grant looking at health equity, and we were able to obtain a grant for the state of Tennessee. I'll be going to Chicago, and we'll be looking at, and one of the reasons is because I think that often we as physician providers don't engage, and so what happens is the insurance company gives us what we don't like, but we don't really engage to get what we like. So we need to be engaging as providers on the front end, nurses, doctors, anybody who takes care of patients needs to engage. Second thing is legislature. We have to provide evidence-based guidelines that are free of bias. I have my own personal preferences and I have my own personal religious background, but that should not affect what the science says about good health care. If we're going to play the game, we, as healthcare providers, cannot allow our healthcare issues to become political footballs tossed around by mostly men and women who just want to be on the team. These are very important issues, and it is life and death for our patients. These are my references. I thank you for your attention, and I look forward to your questions.
Raise your hand if you have a question.
Hi, I'm Jeannie Dasso. I have a lot of patients that don't like to hear that they have a diagnosis of hypertension, and they don't want to do anything about it. And there seems to me to be cultural ramifications of that, and I wish you could speak to that for a little bit.
You are correct. First thing is that those same things that we believe about hypertension are often cultural things that have been passed on in communities. One of the things I've often heard from my African American friends is black people run higher blood pressures. Well, and they're just treating if you treat my blood pressure, I'm going to feel bad. So it takes some time to actually talk to the patient and help them to understand it's not just about treating a number, but it's about treating their life. And the fact that this high blood pressure is going to may increase their risk of stroke, may increase their risk of kidney failure. And if you really sit down and talk to these families, a lot of times they have people in their family with those complications, but they have not been able to really put together that those two things were the cause. And so I just keep on, the same thing happens with diabetics. I just keep on trying to engage them and sometimes you have to see them 2 or 3 times for them to trust you, to know that you're working in their best interest and not just trying to treat them or give them medication. And it has much of that also has to do with the healthcare system and some of the things that have happened in our healthcare system that make people distrustful. So if you have a maternal death in the state of Tennessee, it has to be reported to the committee. We then look at every case and we evaluate whether or not the case, your diagnosis is correct or incorrect. Sometimes, I always call amniotic fluid embolism the garbage basket diagnosis of pregnancy, because if someone dies, that's what they had. So we go through those cases very specifically, and then we determine whether or not we think that could have been preventable. And we may have system-specific things. We may have local recommendations. For example, I was talking about having a hypertensive protocol in your hospital. So if you have a patient that strokes and has, and dies from that, we may come and say, hey, these are the things that can help you prevent this from happening again. It's not about pointing fingers. It's about making us better and making sure that patients are safe when they're being taken care of in our systems.
Have you been able to implement some things in Nashville that you can suggest here in Chattanooga that we could try with our patients, specifically to help them improve their health? Our African American patients, or even the patients that are overweight. Are there some things you could suggest that you've tried that are helpful?
So one of the things I really try especially with my diabetic patients, is a food log. I train, and I know that if I'm not writing down or putting in my phone what I eat, God only knows what goes in my mouth. And what happens is that and I think all of us, if we're really honest with ourselves, stuff goes in our mouth that we're not even aware that went in our mouth. Because we were like in the hospital and we say, well, I'm just going to get this, peanut butter and 3 peanut butter, graham crackers and peanut butter. And then, we didn't think about that was a caloric intake. So diet food logs, having patients keep their food log is one of the big things I use. Another thing that I use is engaging the patient. So when I have a patient who comes in, I ask them, instead of me telling them how their blood pressure is or how their diabetes is, I say, how do you think you're doing with your blood pressure? How do you think you're doing with your diabetes? And often when you phrase it that way, instead of saying, your sugar is 200, that is horrible, the patients will be honest with you. And they'll say, oh, Dr. Graves. And they're also more likely to partner with you when you engage them in that conversation versus this is what you need to do. And then the last thing I think is always ask patients what their resources are. A lot of times we make assumptions that people can have food. In Nashville, there used to be distinct food deserts. Now with gentrification, it's gotten a little better. But I remember specifically leaving my house and thinking, okay, well, I'm going to church. I'll just pick up apples for the children over at the other Kroger. And when I went to that Kroger, the produce was horrible. So I think that that's the other thing we have to do, is to ask patients where they are and provide social support. But I think the food log and me kind of asking the patient what they do and having them keep up with that versus me telling them how to do it has been very helpful in engaging patients and wanting them to make improvements.
Yes, would you address late prenatal care and maternal mortality?
So late prenatal care, there's not a lot of data on entering late prenatal care and maternal mortality per se, although late prenatal care increases the risk of complications and morbidity in particular. One of the issues with late prenatal care has to do, number one, with cultural things. It's not a big deal to have a baby. But more importantly, in the state of Tennessee, one of the reasons we have late prenatal care is because often these patients aren't in the system and cannot get into the system to 20 weeks, which then makes it such that the patient can get not adequate care. So the data for late prenatal care is not as robust. No prenatal care is associated with an increased risk of maternal mortality and morbidity, and an increased risk for fetal complications as well. One of the things we also have to be aware of is that sometimes when people say they have no prenatal care, we've run into this recently, is they actually have prenatal care, but they didn't really like the outcome of what they were told, and so they went to another place to see if they were going to get a different answer. And I have found with many of our patients who are Hispanic, the cultural language barrier, even if you speak Spanish, can be overwhelming. And you have to be just really concrete. I have a patient, I don't know why I have all this pulmonary hypertension. I have I don't know what's going on in Nashville, but I have a patient. And finally I said to her the other day, because she missed her appointment, I said, okay, I need you to understand that you may feel okay now, but when you go into labor, you might die. Got her attention. She's shown up for every appointment since then. Because I think before we were saying, well, this is really important, this could make you, but what she needed to hear is this is really serious, because in their culture, if I treated her with medications, then I may have already solved the problem. So once I told her she might die, she then showed up and had, like I said, and has been compliant ever since.